Okay, welcome everyone for this e-seminar, the impact of novel anti-cancer therapies on blood pressure and kidney function in patients with CKD, what the nephrologist should know and must learn. And it's a great pleasure to moderate this seminar. My name is Kai Schmidt-Ott. I'm from Hanover Medical School, where I'm the chief of the Department of Nephrology. And I'm very happy that we have assembled a nice panel of speakers and panelists who will discuss. And our speaker today will be Jolanta Malyszko. Jolanta is the chief of the nephrology department in Warsaw Medical University. And we'll also have two panelists. And one panelist is Olga Balafa. She's a nephrologist from the University Hospital of Ioannina in Greece. And then we'll also have Mehmet Kanbay, who is the head of nephrology at Koç University Hospital in Istanbul, Turkey. And I very much look forward to this discussion and this topic. I think it's a very important topic. And, you know, where we have little evidence, there's always a lot to discuss. And I really look forward to the discussions. We have already received a couple of questions during the registration process. And please, for all the members who are joining into the seminar, please post your questions in the Q&A if you have questions. I would like to point out that this seminar is organized by the EuReCa-M working group of ERA. And there's also an option for real-time translation. So ERA is launching a real-time translation with audio and captions with artificial intelligence in 7 languages. And if you want to take advantage of this, you have to click on the globe icon, which is on the bottom near the pulse function, and choose your language. And for the captions, an external link to access through the browser will be provided within the chat. And by participating live, the participants will earn 1 European credit for their continuous medical education. And this is an exclusive benefit for active ERA members only. And to get the diploma, attendees must fill in the mandatory questionnaire feedback at the end of the seminar. Yeah, and with this, I would like to get started. And Jolanta, I'm very happy that you prepared to give the talk, and I look forward to your presentation. Jolanta Malyszko.
Thank you very much, Kai, for the wonderful introduction. And honestly, what we did in our hospital, we established the onco-nephrology team with our oncology colleagues, as we do have the clinical oncology department. Previously, they were our neighbors. Right now, they moved to the one building in our campus. Concerning the hypertension in oncology, we do know that the cancer treatment is not, I would say, benign, or is not friendly for the cardiovascular system. On one side, it may cause hypertension, accelerated atherosclerosis, thromboembolic disease, pulmonary hypertension. On the other side, it could be the heart failure, valvular heart disease, cardiac arrhythmias, coronary arteries, pericardial disease. And this is, of course, the price we have to pay for the cancer cell death. Concerning the multidimensional relationship between cancer, hypertension, and cardiovascular disease, there is also, I would say, kind of a vicious circle, because there are interrelations between chronic kidney disease and hypertension, as far as we know that vast majority of patients with CKD are hypertensive. And on the other side, when cancer treatment is responsible for hypertension, it also may lead to the worsening of a kidney function. And all of them, they affect cardiovascular system. There was a very nice review last year published in CKD with a beautiful graphical abstract concerning management of cancer-related hypertension on the risk factors, optimal blood pressure control, and VEGF, and also how to tailor the therapy with the first-line agents. Concerning the onco-hypertension, which is a completely new term, or let's say cancer-related hypertension, we have to think about the pre-existing cardiovascular risk factors. And it could be, of course, the age, comorbidities like diabetes, and also smoking, physical inactivity, obesity, and obstructive sleep apnea. On the other side, we are thinking about the anti-cancer therapy. And also there are some indirect hits of cancer treatment like deconditioning, weight gain, pain, stress, anxiety. And the vicious circle is that there is a mutual relations between hypertension and cardiotoxicity, nephrotoxicity, vascular toxicity of the anti-cancer treatment, causing the enhanced risk of cardiovascular disease and mortality. So on one hand, hypertension may be a risk factor for some cancers. There are some associations between hypertension and the development of renal cell carcinoma in some observational studies. There was also the Metabolic Syndrome and Cancer Project with prospective follow-up of the cohort of more than 500,000 participants for 12 years. And it was the association between the elevated blood pressure with a slightly higher risk of cancer incidence in men and cancer-associated mortality in both men and women. However, the causal clear relationships between hypertension and cancer were not established. So concerning the recent Cardio-Oncology Society guidelines, the definition of onco-hypertension is exaggerated hypertensive response to an increase in systolic blood pressure by more than 20 milligrams of mercury and in mean arterial pressure by 15 milligrams of mercury. In the European Society of Cardiology guidelines on cardio-oncology, there is an acknowledgement that this needs and suggests more lenient treatment threshold, more than 160/100 for asymptomatic patients with metastatic cancer who have an expected survival of less than 1 year. It's also in oncology, there is a very strict and defined terminology of adverse events. And this is the latest version, the version 5 on this is also the part of hypertension, as well as there are some other parts concerning, like for instance, renal diseases, AKI, etc. So the grade 1 is adult systolic blood pressure between 120, 139, or diastolic between 80 and 99. Grade 2, it's systolic blood pressure between 140, 159, or diastolic 90, 99, if previously was within the normal range, or change in baseline medical intervention indicated. There is also recurrent or persistent or symptomatic increase by more than 20 milligram mercury diastolic, or to more than 140/90, or when monotherapy is indicated. Grade 3 is systolic blood pressure more than 160 or diastolic more than 100, when the medical intervention is indicated, when more than one drug or more intensive therapy than previously used is indicated. The grade 4 is for both adult and pediatric, with life-threatening consequences like malignant hypertension, transient on permanent neurological deficit, hypertensive crisis, and in this case, urgent intervention is indicated. Grade 5 is always death in this symptomatology. So this is also another one presentation of the classification of severity of hypertension occurring secondary to anti-cancer therapies. And this is on the publicly available website concerning the adverse effects of anti-cancer therapy. So this is like the summary of different definitions of hypertension in patients with cancer and in the general population. So we can see the nephrology guidelines, NCI's CTCA 5.0 version, or American College of Cardiology, American Heart Association, European Society of Cardiology, or International Society of Hypertension. However, coming to the more clinical part, there are several studies who determined whether there is an association between antihypertensive medications and increased risk of cancer. And right now, because the safety is a priority concerning the pharmaceutical, the trials with drugs. There are three classes of drugs like calcium channel blockers, ACE and ARBs, and thiazide diuretics. They were investigated for potential carcinogenesis, and these particular groups are really frequently used as the treatment of hypertension in cancer patients. So far, there are no conclusive evidence that suggesting that significantly elevated cancer risk and this particular therapy. However, on the other side, there is long proven cardiovascular benefits of these drugs, which outweighs the minuscule potential risk cancer. So concerning the incidence and the mechanism of hypertension in cancer therapy, so we can see that the incidence of hypertension when during the treatment with proteasome inhibitors, it's between 10 to 32%, so up to 1/3 of patients, they experience hypertension or worsening of previously existing hypertension. With CNIs, it's between 30 and 60. With vascular endothelial growth factor signaling pathway inhibitors, it's even up to 90% of patients, they have either de novo hypertension or worsening of the previous hypertension. With alkylating agents is 1/3, rate kinase inhibitors, platinum-based therapies more than 50%, Bruton TKIs, tyrosine kinase inhibitors, it's 70%. With other drugs like aromatase inhibitors, mTOR inhibitors, androgen receptor blockers, it's close to 15%. PARP inhibitors, BRAF/MEK, it's close to 20%. So there are also different mechanisms of hypertension. It could be either more capillary rarefaction, it could be mitochondrial dysfunction, nephrotoxicity, angiogenesis, lower synthesis of nitric oxide, more endothelin synthesis, and more sympathetic outflow. So this is like summary of the incidence of hypertension induced by different classes of anti-cancer drugs, which was nicely presented on the figure, on the previous figure. There are also, from different perspective, a little bit different presentation of the mechanisms. So like with the mitochondrial dysfunction, it could be either in the treatment by calcineurin inhibitors or P1-3K inhibitors, mainly in the breast cancer, or VEGF pathways, which are mainly used for the renal cancers. And on the other side, it's also the elevation of reactive oxygen species, intracellular calcium, and lower nitric oxide synthesis, leading to hypertension. And it may occur during the therapy with BRAF/MEK inhibitors, proteasome inhibitors, and all of them, they lead to the hypertension. So in the cancer therapy-related hypertension, generally the most common causing factors are vascular endothelial growth factor inhibitors, also known as VEGF signaling pathway inhibitors, VSPIs. So increase in blood pressure from baseline is seen in almost all patients on the VEGF inhibitors, with new or worsening hypertension up to 80-90%. However, the positive side is that the incidence of life-threatening hypertensive crisis with bevacizumab has been estimated to be around 1%. I would say the radiation therapy is generally right now used more and more frequently. And sometimes we do see the adverse effects even several years after the finishing of the therapy. And the carotid bar reflex denervation and failure from craniocervical irradiation can lead to labile hypertension, hypertensive crisis. Radiation-induced renal artery stenosis is relatively rare. However, the radiation nephropathy can occur in up to 1/5 of patients following kidney irradiation, and it may present either acute radiation nephritis or chronic radiation nephropathy. But what we could see in the clinical practice, so the radiation nephropathy also may be the risk factor for retroperitoneal fibrosis, and we could see this as late as several years after the therapy. Acute radiation nephropathy usually occurs between 6 and 18 months after radiation exposure. It may be associated, of course, like vague syndromes like fatigue, edema, headaches, or symptoms due to the malignant hypertension like encephalopathy or heart failure. Renal biopsy usually is extremely seldomly, extremely rare, but if it's done, it can show endothelial cells with loss with subendothelial expansion and also thrombotic microangiopathy. Chronic radiation nephropathy can occur more than 1.5 years after the exposure, and it's often asymptomatic. So sometimes the hypertension is just the first sign of chronic radiation nephropathy. And when we did to perform the kidney biopsy, we show we can see the interstitial fibrosis and arterial sclerosis. And usually this kind of hypertension is treated mainly with ACE or ARBs, I mean with nephroprotective drugs. However, there are also non-therapy related factors are like pain, anxiety, depression, sleep problems, and all of them can cause transient or chronic blood pressure elevation. On the other side, we also have to think about the high sodium diet, sedentary lifestyle, tobacco, alcohol use, weight gain, and the weight gain is particularly seen with breast and prostate cancer on hormone therapy. We also may think about the paraneoplastic hypertension, and it can occur due to the release of various vasoactive peptides like endothelin-1, urotensin, adrenomedulin from renal cell cancer, renin and angiotensinogen from hepatocellular cancer, corticotropin-releasing hormone in small cell lung cancer, carcinoid tumor, and catecholamines in pheochromocytomas and paragangliomas. When we try to put together all the anti-cancer drugs and adjunctive therapies, which are commonly associated with hypertension. So on the first place are VEGF signaling pathway inhibitors, with the mechanism like vasoconstriction, endothelial dysfunction, capillary rarefaction, renal injury, and TMA. And the suggested first-line therapy are nephroprotective drugs like RAS inhibitors and dihydropyridine calcium channel blockers. With proteasome inhibitors like bortezomib, carfilzomib, ixazomib. This is mainly due to the cellular toxicity and the nephroprotective measures like RAS blockade is used. With alkylating agents like cyclophosphamide, ifosfamide, busulfan, it's mainly endothelial dysfunction. All these three classes of drugs are used. With platinum compounds like carboplatin, oxaliplatin, cisplatin, it's generally the renal injury, endothelial dysfunction, and lower nitric oxide bioavailability. And also the proposed treatment is 3 types of drugs. Nucleoside analogs, gemcitabine. This is the most common cause of TMA, drug-induced thrombotic microangiopathy, and the nephroprotection is proposed. There are also other types of anti-cancer drugs like BTK inhibitors, BRAF/MEK inhibitors, androgen synthesis inhibitors, are like abiraterone, leuprolide, and in this particular group, mineral corticosteroid receptor antagonists are preferred drugs together with diuretics. With androgen receptor blockers, generally these kind of drugs together with calcium channel blockers, ACE and ARBs. With mTOR inhibitors, everolimus, sirolimus right now is quite seldomly used. It's mainly nephroprotection with calcium channel blockers. With PI3K inhibitors, it's also the same type of drugs. With PARP inhibitors like niraparib, olaparib, it's lower availability of dopamine and norepinephrine serotonin uptake. So in particular, in this group, beta blockers are the preferred drugs together with ACE and ARBs. With calcineurin inhibitors, we know that the drug of choice is generally CCBs. But there are also glucocorticosteroids or ESAs, which are used, and also we do know that they may cause hypertension. So there are these adjunctive medications in cancer. We know, all of us, we do know about the steroids, ESAs, but also what the oncologists are telling us that the NSAIDs are used like candies. So in the, I would say, quite large amount, and we do know that NSAIDs are causing vasoconstriction. So that's why they can contribute not only to the hypertension, but also to the worsening of the kidney function. Concerning the hypertensive effects of VEGF pathway inhibitor signaling, there is a combination of different mechanisms like impaired nitric oxide production, abnormal endothelin and prostacyclin signaling, microvessel rarefaction, increased vascular stiffness, and with the renal effects, which include impaired hemostasis, it's decreased natriuresis, and also increased podocyte permeability, glomerular endotheliosis, and renal damage. But there are also some kind of drugs like bevacizumab and aflibercept. They may also cause the thrombotic microangiopathy. On the other side, the VEGF-A tyrosine kinase inhibitors, they may be associated with the minimal change nephropathy and FSGS. And in the course of these diseases, the elevation of blood pressure. So summarizing the part of VEGF, they affect different mechanisms like trophic effects on podocytes, on nitric oxide, endothelial dysfunction, lymphangiogenesis, pressure natriuresis, capillary rarefaction, and they are causing the volume overload, proteinuria, systemic vasoconstriction, leading to a hypertension. And if we do look at the different types of VEGF signaling, so we can see that like monoclonal antibodies like bevacizumab or decoy receptor scavenges circulating VEGF, aflibercept, small molecule tyrosine kinase inhibitors, they're interrupting the downstream intercellular signaling at various steps, and monoclonal antibodies directed against VEGF receptor. So all of them, they they can be responsible for hypertension. And on the other side, as we do see our patients, they are generally elderly, so they can have not only the comorbidities, but also multimorbidities, like diabetes, like CKD. And if they have these two kinds of comorbidities, of course, we do suggest like antihypertensive medications, RAS blockade. And concerning SGLT2 inhibitors, what I did learn at the last ESN, that of course there are no studies concerning using SGLT2 inhibitors in the cancer patients. At the very first moment, there were some I would say, I cannot say suggestions, but some hints that SGLT2 receptor may be responsible for the carcinogenesis. But from the studies done on flozins, there were no even safety signal. As SGLT2 may also they're also used as nephroprotection, they also can lower a little bit of blood pressure. With chronic heart failure and left ventricular systolic dysfunction, besides ACE and ARBs, there are also ARNIs and beta blockers and loop diuretics. With arrhythmias, there's generally preference of beta blockers. With resistant hypertension, MRAs, nitrates or dihydrolazine, and in the elderly, calcium channel blockers. However, in everyday life, we also struggle with polypharmacy, because when our patients are getting older and they have quite a lot of comorbidities, they're also given administered several drugs, and we should be aware of the interactions between antihypertensive medication and the cancer treatment. And like for non-dehydropyridine calcium channel blockers, they inhibit CYP3A4 enzymes, and as a result is an increased plasma levels of tyrosine kinase inhibitors. And we have to think about it, that they might cause some adverse events. Verapamil decreases excretion of doxorubicin, paclitaxel, and irinotecan, and worsen cardiotoxicity of these drugs. Amlodipine should not be used in patients with VEGF-induced hepatotoxicity because it may enhance the toxic effects on the liver. ACE have a higher risk of angioedema with mammalian target of rapamycin inhibitors like everolimus. With loop diuretics, we have to be careful when using platinum-based therapy because of a higher risk of ototoxicity and nephrotoxicity. Thiazide diuretics may potentiate cyclophosphamide-induced myelosuppression. Certain TKIs can cause QT prolongation, and in the combination with beta blockers, they may be increased risk of post-dependent tox de points. And also other non-VEGF TKIs like imatinib and gefitinib, they can increase metoprolol levels and worsen bradycardia. These effects are even more pronounced with crizotinib and ceritinib, and they cause additional bradycardia. So that's why we have to think about also the interactions. Spironolactone should not be used with abiraterone because it may interfere with the antiandrogenic effect and can cause an increase in prostate cancer growth. When spironolactone typically carries anti-androgenic properties and it's believed to be protective against prostate cancer, in an androgen-deprived environment created by the androgen synthesis inhibitors, it behaves paradoxically as a selective androgen receptor modulator, and that's why it exerts paradoxical pro-androgenic effect. Eplerenone is a safe alternative to spironolactone. Concerning the non-pharmacological approach or lifestyle modifications, patients receiving VEGF inhibitors are more sensitive to sodium load because of the impaired natriuresis. And the sodium-restricted diet is, I would say, friendly because it's reduced the risk of VEGF-induced hypertension. And also, patients should be counseled to avoid substances which may exacerbate hypertension, like caffeine, smoking, alcohol, and NSAIDs, in particular during the active treatment. And this is the most recent paper from the American Heart Association on the cancer therapy-related hypertension. And the practical point is like, what shall we do before cancer therapy? And first of all, okay, we have to know whether the patients are hypertensive or not, whether we can initiate lifestyle modification in the therapy, or to initiate treatment, and also to think about the secondary hypertension. So the goal is to optimize blood pressure control prior to starting anti-cancer therapy. During active treatment, we need to optimize blood pressure values. And the first-line agents are the same as in general population: ACE or ARBs, calcium channel blockers, thiazide or thiazide-like diuretics. And also we need to consider the comorbidities in selection of agents, and we have to think also about the adequate management of pain and anxiety. And after the cancer therapy, also we have to closely monitor the blood pressure values to look for development of hypertension or worsening of blood pressure control and associated target organ damage. And that's why we need to closely follow up the patients, like with ECG, cardiac imaging, creatinine urinalysis. And in general, it's mainly done by medical oncologists, sometimes by PCPs. However, in the real life, it's generally not so easy to make the adequate follow-up of patients in every aspects. In oncology, yes, but in the other sides, it's generally given to the hands of internists and the PCPs. So they also proposed the approach to home blood pressure monitoring in cancer patients and survivors. And if the blood pressure is out of office more than 130/80, there is a question whether it's a high-risk anti-cancer therapy. If no, well, we can leave to the monitor home blood pressure twice daily. And if yes, we need to think about the titration of antihypertensive medications and, of course, the monitor home blood pressure. If it's more than 160/100, we also need to treat adequately and monitor blood pressure control. Concerning the treatment, if there is also question of proteinuria present or not. If the proteinuria is present, first of all, we need to think about the RAS blockade and try to up-titrate the dose to the maximum tolerated doses, and then add other drugs, mainly the dihydropyridine calcium channel blockers. If it's not enough, we need to think about adding and titration of mineralocorticoid receptor antagonist, or to add the beta blocker. And also, if we obtain the maximum tolerated dose and still there is the values of the blood pressure is too high and it's hypertensive crisis, we need to consider the drug holiday for chemotherapy or the reduction of the doses. So what is the most important thing? It's first of all that this is a diagnosis of hypertension and adequate or appropriate treatment before the cancer therapy. And if there is exacerbation of the hypertension during the active phase of treatment, we need to optimize treatment of hypertension, and also to regular monitoring of blood pressure during cancer treatment. In particular, we do not have so many drugs as the first choice. It's a RAS blockade and calcium channel blockers, dehydropyridine derivatives. So in conclusion, many anti-cancer drugs may worsen blood pressure control in patients with existing hypertension. Hypertension control is very important before, during, or after completion of cancer treatment. At least weekly blood pressure monitoring is suggested for the first 4 to 8 weeks for patients on cancer drugs that increase blood pressure or on discontinuation of these drugs. And also, we do encourage the home blood pressure monitoring. We do know that the contemporary cancer treatment have significantly improved cancer survival at the expense of cardiovascular toxicities, including heart disease, thromboembolic disease, and hypertension. One of the most side effects of these drugs is hypertension, in particular in patients on VEGF inhibitors and TKIs and proteasome inhibitors. There are also adjunctive therapies like steroids, calcineurin inhibitors, non-steroidal anti-inflammatory drugs, and anti-androgen hormone therapy for prostate cancer may further increase blood pressure. And as the population or cancer survivors is increasing, there is also increased risk of hypertension-associated complications like chronic kidney disease, heart failure, and atrial fibrillation, which necessitates awareness of these particular complications. Thank you very much.
Thank you very much, Jolanta, for this very nice overview and the complex topic of blood pressure management in the setting of cancer therapies. Before we enter the discussion, I would now suggest that we move on to our panelists and we get a brief statements of the panelists, whether they would like to add some aspects or whether they also want to contribute their own experiences with managing cancer patients and the nephrological aspects to the management of cancer patients. And Olga, would you like to start?
Thank you very much, Kai. It's really great to be with all of you today here. Jolanta, it was a really very nice and thorough presentation about hypertension and cancer patients. You said everything. Really, I don't have to add something. I found really interesting the part about the interaction between the medication. My clinical point is that don't neglect the hypertension in cancer patients. We try to focus on the cancer and the treatment of the cancer, and we don't pay attention to hypertension unless it's too high. And that's not the right way, because our patients, as you said, are going to live longer and longer, and they are going to die of cardiovascular disease, not of the cancer. So please treat hypertension. That's the message. Now, if we're going to talk a bit further about onconephrology, my main problem when I go to the oncology department has to do with the dilemma to biopsy or not to biopsy when I have a patient with proteinuria and TACI, hypertension, CKD and TACI, and so on. And I really want to hear your what do you think about this, your thoughts? Because sometimes from a scientific point of view, I do really want to perform the biopsy, but the patient, the status of the patient is poor, or the platelet count is low, and it's not safe, or it's not appropriate to perform the biopsy. And then I have to think about it. And yes, if I think about a glomerulonephritis, maybe I have to go on. The last year, more and more oncologists start to try corticosteroids without the biopsy, and they say, okay, if we don't see a progress, maybe you can perform the biopsy later. What do you think about this? Because this is my dilemma in everyday clinical practice, when to perform the biopsy.
Honestly, Olga, we do have the same experience. The one point is we are fortunate enough that we do have the medical oncology department in our hospital. So that's much easier. And because in general, they do accept the much sicker patients. So we offer them more and more often kidney biopsy. And we do have the proof like for TMA, that it's really TMA and nothing else. Or the other glomerular diseases. This is one point, or acute interstitial nephritis or acute tubular necrosis, something like that. For us, a little bit different problem is that we also do have the National Institute of Cancer, and they do not have the nephrology service. So one of our colleagues serve as outpatient consultant once a week, but it's not enough. So that's why if we are dealing with patients with worsening of a kidney function, so we do admit them to the nephrology department, and our oncologists, we try to make some kind of conciliary care or the common meetings, try to discuss what the best option, in particular when we are dealing with the nephrotoxic anti-cancer therapy. So sometimes we try to figure out that which kind of the protocol from the oncology perspective is feasible, doable, and how we can manage the our CKD care. It also happened to us that if we did have the patient with a testicular cancer, and the oncologist thought, okay, this is very well, the prognosis was generally very good. So they decided the GFR was close to 20 at the time. So because in the protocol, they use the platinum derivatives, so we decided to start dialysis, enable patients to be treated with a full dose of the treatment. So we did like that way. Also in another several cases, like there were also some nephrotoxic protocols concerning the either lung cancer or ovarian cancer. We tried to figure out what is the best dialysis regimen. And owing to the discussion, like we after the chemotherapy, we start dialysis to eliminate the toxic metabolites. So it was like the patients were admitted to the oncology, they were given chemotherapy, and then we started dialysis to eliminate toxic metabolites. In the case of kidney transplant recipients, it was also the situations when with the graft failure, when the oncologist proposed the treatment which were potentially nephrotoxic, we discussed with the patients whether they will accept also the start of the dialysis treatment to enable I would say, the full dose therapy. And generally, it is a very, very, I would say, individual way of treating this particular, I would say, these particular patients.
Yeah, thank you for these statements. And I completely agree that there's very little evidence for what we're doing in these very specific scenarios, and we'll never have clinical studies to support our decisions. It's always retrospective analyses at best, you know. So thank you, and let's hear the perspective from Mehmet then.
First of all, I think the best clinical approach for these patients is to decide case by case, and we have to have a close relationship with oncologists, and we have to tell them that if the patient has AKI or CKD, this will be related with poor outcome. And this is the first point. Regarding the presentation of Jolanta, of which is excellent and fantastic, thank you. I do not recommend to start SGLT2 inhibitors because these patients are immune compromised, and there is a significant risk for euglycemic ketoacidosis. This is the first point. And the patient generally may need operation or some surgical procedures that we may need to stop, and oncologists may disregard to stop these agents, and this may cause severe complications. This is the first point. And also, as Jolanta mentioned, we have to alert oncologists to not start non-dihydropyridine calcium channel blockers, of which patients use VEGF inhibitors, because these kind of medications may increase the plasma levels of these drugs. This is the second point. The first point is, another point is, we have to decrease the threshold for doing kidney biopsy to increase our clinical experience and to learn more about this. And the other point, we have to write our own guidelines. Unfortunately, onconephrology guideline papers, generally, almost many of them published in oncology journals. And if you see, the first and the last authors are oncologists. Mm-hmm. I wonder, for example, if you have a patient with interstitial nephritis because of immune checkpoint inhibitors, should we start again or not? Mm-hmm. Should we start with steroids or without steroids? Because this is very important. We may discuss this. And another point is, as my colleagues mentioned, these drugs may cause TMA, glomerular problems, tubular problems, and fluid and electrolyte problems. And if we don't see these patients, this may cause a delay in the treatment, mm-hmm. of which related with poor outcome of these patients. So we have to have a close relationship, and we have to have a separate nephrology clinic of which see in and outpatient only oncology or cancer patients. And this will help us to increase our knowledge, experience, and this will improve the awareness of this important topic. Another point, the number of the kidney transplantation patients increases. And in this population, the malignancy significantly increased. So should we give immune checkpoint inhibitors, of which related with increased T cell activity and may cause rejection or increased rejection? So should we start without, don't look in kidney function, or should we don't? This is another point. Also, another important topic is that we have to keep in mind that if we don't do or see these patients, oncologists only will focus on chemotherapeutic agents. They will never look at kidney functions, proteinuria. And this is these are my comments, and we will discuss according to these questions. Thank you.
Honestly, if I also, thank you very much, Mehmet, but I just mentioned flozins because the people are coming more and more, mainly from cardiologists. So that's why there are sometimes questions, what shall we do? And I totally agree that we have to be careful. This is one point. And second point, or here is we're talking about hypertension, but generally for us, the major issue is when we start, not we, but when the oncologists start ICIs and something, well, right now, I don't know how it's in your country or in other European countries, but in generally, in our nephrology department, we do have the residents. They are doing the internal medicine part from their specialization of medical oncology. So they can see the diagnostic procedures and all the complications. And in oncology, they have the treatment, the active treatment. So let's say our residents, well, our oncology residents, they have the whole portfolio. But in other places, in oncology, They are doing only treatment. The diagnosis is done by someone else. And all the complications, they don't see any complications because they do not admit patients to oncology departments. So that's why I cannot say we are fortunate enough, because it's not the proper word, but we are fully aware of the nephrotoxicity of oncology treatment. We do see the complications, and that's why we are really, I would say, the best or the appropriate partner for medical oncologists to discuss different issues. And also, like, I don't know how it's in other countries, how it works, but in Poland for oncology, they do have the certain limits for drug administration, like for many TKIs or VEGFs inhibitors, there is a cutoff point of creatinine, like 2 is the highest creatinine. If the creatinine is higher, the oncologists are not allowed to give certain medications. So this is the strange, because when the patient is on dialysis, the patient is allowed to be treated because there is no cutoff points for creatinine. So, well, I don't know how it works, but that's why we do learn more and more of the nephrology complications of malignancy treatment.
Okay, thank you for raising these important points, and I will try to now address these topics. And I would like to point out that we also have a few questions in the chat. Yeah, and we have these questions concern ICIs, again, immune checkpoint inhibitors. And I think it's already been raised. We have the specific setting of the transplant patient and the GN patients who are already on, you know, immunosuppressive treatments, and now we treat them with an ICI. And this is sort of obviously the opposite of an immunosuppressive treatment. And according to what the numbers that I know, we have approximately 40% of patients rejecting their transplants, and probably high rates of reactivation of autoimmune disease when immune checkpoint inhibitors are initiated. But then, of course, we have this huge dilemma. These are amazing therapies, right? And they are very good for cancer treatment. And maybe they're the last option and resort to treat the patient and to save the life of the patient, or at least to prolong the life of the patient. And then, of course, as nephrologists, of course, the kidney is always replaceable, right? So in the end, we oftentimes will have to make you know, informed judgments and discuss the specific situation with our patient. But Jolanta, I would like to hear your view on you know, ICIs, and you know, maybe I should point out that Jolanta and I and many other researchers from Europe, we have founded a consortium to elucidate the mechanisms, but also the specific you know, clinical settings of ICI-associated acute kidney injury. And this is a huge problem, in my opinion, and we need to address it in a better way. And maybe, Jolanta, would you like to comment on these specific settings, but also would you maybe before that also outline to the viewers what is the general management of patients who would exhibit AKI in the setting of ICIs?
And also, should start ICI again or not?
That's an important question, and we will come to that, definitely. Yeah, yeah.
At the very first moment, of course, I will have to think about the steroids.
Yes.
Well, and the issue is whether we plan to do a biopsy or just to start steroids like oncologists do. From the nephrology perspective, well, I cannot say gut feeling, but our thinking is that if there are conditions to perform the kidney biopsy, it's better to do it unless there is like problem with low platelet count, etc. Because well, first of all, we know what's going on, whether it's real interstitial nephritis or tubular necrosis whatsoever, or maybe there is another one, pathology, which could be treated differently, which may also affect the outcomes. This is one point. Oncologists, they start with steroids immediately, without even calling nephrologists. So this is one point. The second one is that concerning the re-challenge, I would say we do not have the hard data. What shall we do? From the oncologist perspective, they would like to put patients on ICI again, in particular when there was a very good response, a complete remission or partial remission. However, sometimes we also may rather oncologists together with nephrologists may consider the option like to re-challenge, but not with the same drug, but the drug from the same family, like not with like of course, if there are indications like with the pembrolizumab, with nivolumab or ipilimumab. So sometimes this is also the consideration, the re-challenge with a drug, the different drug, but from the same class.
Yeah, Jolanta, this is a very important point.
Time? Sorry.
Oh, sorry about that. Yeah,
go ahead. Start low-dose steroids at the same time when you start the drugs again, ICI, I mean, or not?
Generally after steroids, not at the same time when you start steroids.
So the normal course will be to do a steroid treatment course for about 4 to 6 weeks, I guess, right?
Yes.
Hope that the kidney function will resolve, and then restart the ICI thereafter. I would like to point out that there are a couple of retrospective studies showing that the recurrence rates are quite low with restarting ICIs. Yeah. In one study, it was only 16% that had recurrence. So I think we have to use sort of different standards when we compare it to tubular interstitial nephritis from other origins. You know, when we have a tubular interstitial nephritis associated with an antibiotic, we usually say, don't use that antibiotic again. But in the case of the checkpoint inhibitor, it's very fair to re-challenge the patient and try that. Yeah.
I think.
And also, sorry, some studies recommend to stop to use, if possible, proton pump inhibitors.
Absolutely.
And also NSAID.
I think the problem is if the case is interstitial nephritis, we can re-challenge. But if the case is a glomerulonephritis, how can we proceed? That's a more difficult question to deal with.
For me, it's also the matter with the discussion with oncologists. Maybe we can just combine at the same time steroids plus ICI, or sometimes we also may consider like a mycophenolate mofetil plus ICIs in the treatment of glomerulonephritis. But I think there are not so many cases, so that's why it's very difficult to draw, I would say, conclusions.
So let's get back to the topic of prophylactic dialysis. I thought this was really interesting to hear your thoughts on this. I'm not really aware that we do this a lot, to do prophylactic dialysis in patients with who are treated with cancer therapies. But you pointed out a case where the GFR is really low, and I guess to adjust chemotherapy dosage, that was the target here, right?
Yes, it was one point. And the second one was that in patients with advanced CKD, decreased kidney function, there is much higher risk that the toxic metabolites are much more toxic than the drug itself. So the idea was that after the chemotherapy, wait like 4 hours or so for the drug to bind to the protein, and then to start dialysis to take out or eliminate all these toxic metabolites.
Okay. There's one other question from the chat. Do you use non-steroidal MRAs as well?
We didn't use.
Yeah, so I think here so for non-steroidal MRAs, the only indication is CKD plus diabetes, right? And if I have a cancer patient who has CKD and diabetes, I may of course consider it, but otherwise I think there's no current.
The patient may have neuroendocrine tumor of which synthesize too much ACTH or cortisol, and the patient may have low potassium level, and this might be a good option in this kind of cases. Otherwise, no need to use.
All right. So I think we discussed a lot of these topics. The time is already very advanced, and I think it's also a quite extensive topic. You know, all the different cancer therapies and their, you know, kidney consequences and consequences for the nephrologists. And of course, within 1 hour, we can only, you know, touch upon a couple of topics. But I think this has been really nicely achieved by the current panel. And I would like to take this opportunity to thank all the participants. Thank you to Jolanta for giving the nice speech. And thank you to Olga and Mehmet for giving their personal insights. And I think it's a hot topic. It's an evolving topic, and we'll learn a lot in the future about this. And thank you to the audience and for being part. And